Hi there, welcome to the second podcast on the care of the post-operative patient. My name is Sarah Muhammad Ali. I'm one of the interns.
And I'm Dr. Kim, Ed Kim, colorectal surgery at UCSF. In the last podcast, we went over how every operation has a typical pattern of recovery. In this podcast, we're going to discuss how the overall health of your patient can alter the usual pattern of recovery and how you should adjust your expectations based on your patient's preoperative condition. It shouldn't be surprising that different people behave differently after the same operation. The trajectory of recovery we learned about previously is an average of what we can expect.
Sure.
But none of us are average, are we?
No, we're all unique individuals, Dr. Kim.
Yeah, but we're not talking about personality. We're talking about physiology here,
Yeah,
okay?
of course. Yeah, you shouldn't expect a 90-year-old debilitated patient to recover the same way as an otherwise healthy 50-year-old individual after a sigmoid colectomy.
So what do you think makes your patient unique or different from the average patient?
Well, before we start talking about differences, we should recognize that the expected trajectories of the different operations are based on the average of those people that undergo them. So the average colon cancer patient is typically, in their 60s, and so you can expect some comorbidities calculated into that average.
Great point. I think it's important to point out that to truly stand out as an anomaly as a patient, not that you would want to, your patient would have to have some major significant medical problem, right?
Sure. Mm-hmm.
So like hypertension and well-controlled diabetes really don't count. I think things like
CHF or like CAD.
Yeah, COPD.
And renal failures, something like that would be more types that you would likely have an impact on the recovery process.
Right, and medications like Plavix, Coumadin, or things like steroids or any immunosuppression
Sure.
would be a big deal. And your guys' favorite, right, chronic pain requiring narcotics, those can be very, very challenging. They can definitely increase risk both for complication as well as slower recovery with longer hospital stay.
Yeah, and I think it is important to point out that it is certain that they will have
It isn't certain, right?
Yeah, just that they have a greater risk, maybe.
Right.
Okay. I think we see a lot of high-risk patients who sail through the post-operative period, for instance.
Yeah, exactly. So it is not certain that they will have problems, but that they're a higher risk.
Sure.
So what does this mean? So knowing that your patient's high risk, I mean, what does that do for you?
Well, I think it does no one any good to be nervous or anxious about the patient like that. I think you just have to take practical steps and be proactive. So, for example, you could not put the patient on the standard recovery protocol if you know if they're higher risk patients.
Right. And you're going to run into some people who are going to say you need to be vigilant about everybody on your service. And I have to disagree, because we're all people, and you can't be equally attentive to every patient. And I think it makes a lot more sense to know who the patients who are high risk and be more attentive for those people and anticipate problems in those people as well. That's not to say that you should ignore your other patients, but...
Sure. Well, let's take an example here. So, for instance, you have a patient who's post-op day 5 from a lap right hemicolectomy, and you have a white count increase from 8 to 15. The patient hasn't had a full return of bowel function, but you see him and he looks okay. The rest of the numbers are fine. So in an average risk patient, an isolated abnormality like an increase in WBC would raise minor concern. And you could probably just watch them for now, because of a lot of the time this just means nothing. But if you have a patient that has an obstructing tumor with liver mets and lost 20 pounds, 30 pounds in the weeks leading to the surgery, you'd probably be more vigilant about this workup. You would get a full infectious workup, get a CT scan, something like that.
Yeah, that's right. So you're saying that for high-risk patient, you basically are lowering the threshold to initiate treatment or order additional tests. Is that right?
You just have to be proactive. You look for first signs of a problem. It doesn't only have to be about the operation itself, but you also have to know the background of the patient and how they presented. So if you have someone with a bad COPD, you make sure that they have good pulmonary toilet, and you take any complaint about their respiratory status and breathing very seriously.
Okay. So I think we can summarize, I think it's best to summarize by combining the concept of our first two podcasts.
Yeah, that you can predict what your patient's recovery will be or look like based on how sick they were before the surgery, or how complicated and traumatic the procedure was.
So the two factors combine to give you an idea of how they're going to recover.
Right.
Well, this is excellent. I think this points to the idea of providing individualized care. It means that we make adjustments to our expected trajectory, and it helps you kind of realign whether your patient is on or off trajectory.
Yeah.
Right? And just as important, it means that for high-risk patient, you should anticipate problems and be proactive and identify early signs of trouble and expedite treatment.
I agree. And in our small group sessions, we'll go over kind of what the typical risk profile of patients on the service would be and how to stratify these individual patients. So we will ask that you bring your service patient list, and we can go over who you can anticipate to encounter problems in their recoveries, and those who would have an uncomplicated trajectory.
Great. Thank you for listening.
All right. Thank you. Thanks,
and
Dr.
we look
Kim.
forward to seeing you guys.
Alrighty.